I'm Dr. Shadi Vahdat, Chief Medical Officer at Create Cures Foundation, here today with Professor Valter Longo. I'm excited to be kicking off what I hope will be the first of many such conversations where we work together to bridge the research and science of nutrition, fasting, and longevity with the actual care of patients in clinical practice. Our topic for today will be all things related to colon cancer in honor of Colon Cancer Awareness Month. Of course, while the focus is on this particular disease, many of our conversation will have great relevance to many other types of cancer as well. Globally, colorectal cancer is the third most common diagnosed cancer in males and the second in females, according to the World Health Organization. It is estimated by the year of 2030 that 2 million new cases of colon cancer will be diagnosed with 1 million deaths. Aside from familial syndromes like Lynch syndrome, inflammatory bowel disease, pelvic radiation, and chronic immunosuppression, age is a major risk factor for sporadic cases of colorectal cancer. If you look at a chart looking at the incidence, you can see that after the fifth decade of life, the incidence of colorectal cancer rises sharply each decade after the fifth decade. In your book, Professor Longo, you discuss aging itself as the main risk factor for not only cancer, but for many other chronic diseases. Can you explain why we all start falling apart after the fourth and fifth decade of life, and what systems in the body start failing, which predisposes to cancer?
Yeah, so we don't necessarily fall apart, but there is what I call a youth period, a youth span period, where which realistically now lasts until about age 40, where most people are perfectly healthy and they can perform at the maximum level. And then you have a transition period, maybe that in different people lasts differently, going maybe from 40 to 60, 65, and then of course you have the 65 and above related dysfunction, and so it's progressive and it can be very different. So we like to think more about biological age than chronological age. So some people can be 75 and really biologically be 50. Not too many people, but some are. And so I wouldn't worry so much about chronological age. I will worry about trying to stay as young as possible, let's say. And so we know that nutrition is one of the ways to do it. I'm sure we're going to talk about it in the interview more in depth. And what happens with colorectal cancer, what happens with breast cancer, what happens with many cancers, not most of them, let's say the majority of cancers, is that you have mutations, right? So that those can accumulate in different cell types, including those of the colon and the rectum. And then you have the immune system, immunosenescence. So the immune system declines and starts struggling being as efficient as it was before. Then you have inflammation. So the body now, lots of different areas of the body have inflammatory states, meaning there are some cells, some of them are old cells, senescent cells, that cause inflammation. And what does inflammation mean? It's essentially the dysfunction leading to an immune-like chronic response. And this immune-like chronic response is really there to fight viruses, bacteria, cancer cells, but sometimes gets confused. And so now that also contributes. And then finally, the tissues, all tissues get older. And so this allows, for example, metastasis to occur more readily because what may, for example, be a mechanical limit to the cancer as the body gets older may be more permissive. So now a cancer cell can get through it when it would not get through it in a younger person.
So essentially, as we age, all of those issues, inflammation, genetic mutations have additive and are failing or compromised immune system have an additive effect, increasing the risk.
Yes.
Now, go ahead.
Yeah, no. I mean, as far as we know, all of those are very important, and now it's very clear. For example, from the effect of the efficacy of immunotherapy, right, against multiple cancers. That tells us the immune system is very good at. Lots of immunotherapies, all they do is just make the immune system do its job, right? So they remove these inhibitors of immune cell-dependent attack of cancer cells. So once you remove the inhibition, the immune system is very good at killing cancer cells, and so is just an example. So we have lots of evidence that all those factors are involved. For example, an interesting study was done years ago where they would look at they would implant a tumor in an inflamed area of a mouse versus a non-inflamed breast tumor, right? So, and these we're thinking about surgeries. Right? So surgery itself can cause inflammation. So if you take a mouse and you cause an inflammation by a surgical procedure, and then you implant the cancer cells, they survive much better than if you implant it in a place where there is no inflammation, right? So so these are some of the supporting evidence for the things that I say.
Makes perfect sense. The good news, I think we can say, whether in the US or globally, is that we're actually, because of screening for colorectal cancer, we're actually doing a very good job of diagnosing and treating in the elderly. But the problematic issue is that the younger patients, age 20 to 50, actually the cases are rising, not only in the US, but in many parts of the world. And they're increasing at an alarming rate of 2% per year. And so the reason I asked you the last question is because I'm wondering, first of all, these people are going to be the ones that are missed because there's no screening protocols for 20 to 45-year-olds now. And we need to be doing a better job of thinking who we need to pay attention to. So how do you explain the risk in these younger people and someone who's 20 or 25? Why are these cases going up? Is it a different process than what's happening in aging?
Yes, the epidemiology is usually fairly complicated, and no matter what I say, someone will come up and say, "Oh, there is an epidemiological study that shows that's not the case." I assume that nutrition plays a big role. I mean, the epidemiology is not that clean cut. I think red meat is certainly associated with colorectal cancer and a few other things. But it's, what's happening now, I think at a younger age, there is worse and worse diets, and it would not be surprising. Let's put it like that. If that was very central. So, for example, we've seen in Europe, in Southern Europe, we've seen children eating 3 to 4 times more protein than the pediatrician recommend, the pediatric societies recommend. So now imagine now this child, and it's hard to handle this in epidemiological studies because there is really no history, right? So, but now imagine 3-4 times more protein. In the United States, it's probably very similar. So you're exposed, you hear about proteins all the time. Now we think of, protein in the diet has been a very positive thing. And if you ask people, what do you look for in a food? And they'll say, and protein is one of the major things that they'll say as a healthy. And of course, a certain amount of protein is necessary. But when you eat twice as much, 3 times as much, you get a problem, right? So, and we've shown that actually in 2014 in an epidemiological study, people that had the highest protein intake, they had a 3 to 4-fold increased risk of developing cancer, of dying of cancer, of all types of cancer. Right? So yeah, it is possible that these younger people now eating 2-3 times more protein that that the American Medical Society Association recommends. They could be at risk, and it would not be surprising if colorectal is one of the cancers affected. And is of course it's not just the protein; it's also with the types of food that the inflammatory foods they consume. Fast food, but not just fast food. Also, being, let's say, overweight or obese and creating an inflammatory state, creating let's say a steatosis, or high levels of fat in the liver, and all of that contributes to systemic inflammation. And now you could have that aging effect that I just described, brought forward by a couple of decades in some people.
Yeah, just a a note on that. I mean, even in my age, I remember when I was little, I would be told, if you don't eat meat, you're not going to grow up. And so to this day, I'm still fighting that thought that you have to have meat in the diet. So yeah, too much protein.
And it's very interesting because in the book, in my third book, so far it's only in Italian, we looked at the people, at the children that were on the lower side of protein intake. And actually, we looked at the people that had excess protein intake, the children that had excess protein intake, 3, 4-fold or whatever. And then we look at what advantage there was in growth compared to everybody else. And there was like almost no advantage, right? So it was interesting. They were eating all this protein, thinking what you just said, but not really getting any of this. And we're talking about thousands of children. So it's, it's a fact, right? So of course you have to have enough proteins, which for a child, we put about 0.9 grams per kilogram. I think it turns out to be about 0.4 grams per pound of body weight for a child. And and so that's what probably maximizes health and also growth.
I want to get into a little bit more prevention and what age a little bit later. But when we talk about prevention, I know that there's some animal studies in rodents and monkeys that caloric restriction can decrease the incidence of cancer. Can you tell us, what do we know about humans and prevention and these dietary interventions?
Yes, we know that in our study that I just mentioned, and a few I did a follow up with Ed Giovannucci at the Harvard School of Public Health, and we know that people that have a low protein diet, they seem to, at least up to age 65, 70, to be protected from cancer mortality. And we also know that if you go a little bit higher, but you have a mostly vegan, plant-based protein sources, that seems to be not bad for you. So if you can have lots of proteins, try to at least have lots of plant-based proteins. And so so those are some of the aspects of calorie restriction that seem to be key. So the protein restriction within the calorie restriction. The calorie restriction itself may not be such a good idea for people, just because if a person was to become calorie restricted, they will really be pushed to a very low body weight, lots of lean body mass loss, muscle mass loss, etc. So I think it's better to maintain a normal weight, stay on that 0.35, 37 grams per pound of body weight. So if somebody weighs 100 pounds, you need about 40 grams of protein per day. And somebody weighs 150 pounds, that would be about 60 grams of proteins per day. So I think that that's much better than becoming calorie restricted. Now, of course, we've been studying what happens if you do periodic fasting mimicking diets, and so that in mice, if you take a mouse middle age and you start doing this periodic fasting mimicking diet, we show that we reduce cancer tumors by 45%, doing nothing else, right? So that's an interesting observation. So I think that.
How frequently is that with mice?
That was done twice a month for 4 days in the mouse. Of course, in people, we've done a clinical trial where we did 3 cycles of the 5-day fasting mimicking diet. And that showed, for example, a reduction of IGF-1, a reduction in inflammatory markers, a reduction of obesity or fat deposition. And so those are all changes that you would that are associated, or most of these changes are associated with improvement or reduction of cancer incidence. So I think that's the key is to follow a probably pescatarian diet, or a vegetarian diet, so fish plus 2 or 3 times a week, plus a plant-based diet. And then maybe do some type of fasting mimicking diet maybe 3 times a year. So that seems to be ideal. And really, all of this should be about also maintaining normal weight, normal lean body mass. You don't want to lose muscle, and maintain the markers that I just discussed, low. And of course, I encourage people to come to the Create Cures clinic because I'm assuming most people that listen to this will say, I have no idea what you're talking about, and what is IGF-1, and what are all these things that you're talking about, and how can I get somebody to help me get through it? So I think that the clinic is the way to go, right? Yourself and the dietitian and everybody else there.
Yeah, I think people who have read the book or know the principles of the longevity diet still wonder what it is that we can do at the clinic. And knowing the principles of the diet is a good starting point, but everybody's different, and so we really look at those markers, and we are checking glucose, and we are it's a very precise process, measuring patients' protein and watching blood sugars, and everybody, an obese patient is going to have to do different things, and someone with other types of risk factors. So you have to personalize in the end. You can know the principles, but we use the labs and the testing to fine tune our dietary recommendations. So we go a layer deeper when patients join us at the clinic. I wanted to, before I kind of move on to the risk factors that affect screening, you mentioned, I don't think your new book is in English yet, so I've not read that. But when you're talking about, kids versus, 20 to 40-year-olds versus, over 65, do you differentiate in terms of the protein source? I know for older 65, we liberalized a little bit in terms of the, animal proteins. What about in children and younger people?
Yeah, I don't think I wouldn't go as far as saying we liberalize it. We increase it, right? So we basically say, if you're 75, 80 years old, it's okay if you have, let's say, red meat once a week. It's okay if you have more eggs. It's okay if you have chicken. And so more of a Mediterranean diet as we move to a 65, 70 year old person. And why? Because the body becomes it becomes more difficult for the body to assimilate and build, right? So the older, it needs more to do the same. And so the different stages are gonna make a big difference in the way people should eat. So we think for children and for elderly, the Mediterranean diet is probably a good way to go. It's very safe. It's been studied for a long time, and until we have much better understanding of how that can be modified for the very young or the very old, I think we go with that. But the 20 to, let's say, 70 group, so that 50 years central in life, I think there are all kinds of changes that they need to be done. And I think that, and not just for cancer, but we're talking about cancer now, but also, for example, the microbiota, all, of course, that it's going to be central in colorectal cancer. We still fully don't understand how. Lots of papers there, but, so, for example, if you're allergic to walnuts, now walnuts, very healthy food, right? And there's the New England Journal of Medicine meta-analysis showing that they're protective. But the walnut, the same walnut that's going to be helping lots of people live longer, it could contribute to microbiota changes that then give you the colorectal cancer, right? So now you have a constant inflammatory state because you're eating walnut, and we just, in Italy, we had a famous person that had been struggling for years. I cannot say the name, but he's struggling for years with celiac disease. And this person didn't know. And so was going through hell just because of an autoimmunity against gluten. Right? It's just a single thing. Then this person removed that from the diet, and all of a sudden, doing very well. So so I think we appreciate gluten and we appreciate celiac disease, but there's probably 100 examples of that we don't yet appreciate. And so I think that those are the things that we need to do more work on, and each person has to pay attention. So pay attention. Is there certain foods or certain things that you do that you feel are associated with problems, particularly in your gut, because that could be a big problem if you let it go for 20 years.
But you know what I see in clinic is so many people get used to these chronic symptoms and they just think that it's part of being normal. It's like, oh yes, I'm bloated. Of course, it happens. And that is a sign. You should not get bloated with food. And a lot of what I do is look for these, food allergies, because patients are not aware. They're used to being, having runny noses or being tired or having achy joints, and it's their norm. And
it gets worse. Because not only, like you say, they get used to it, and I think, and you and I collaborate on lots of this, but I think that even a small hint of a painful situation should tell you something is wrong. A small hint, when you start feeling like something is out of whack, I don't know why. Think about what you just had, because eventually that could become pain. And then it could become inflammation, and then it could become a nightmare, because then to come back once, and we know now probably antibiotics are going to be involved, maybe some of the anti-inflammatory drugs could be involved. We don't know yet, but certainly things that disrupt your gut microbiota together with that food, let's say gluten for the celiac people, but who knows what kind of foods. And this is something now we're actively testing in the lab. We're starting to look at common foods. What about tomatoes? What about potatoes? So we're looking at common food, and we're looking at gut inflammatory responses. And we're starting to see some really interesting results. But anyway, so pay attention to that. And then the bigger problem is give drugs that now, instead of solving the problem, let's say the microbiota now, you take antibiotics, you wipe out most of the bacterial population, or you certainly disrupt it. You probably create an inflammation, and then you start eating foods that may contribute to that inflammation, right? So now you go to the doctor, and the doctor might end up giving you maybe more antibiotics, which in some cases, as you know better than I do, can be useful if they're part of a plan, right? So if you give antibiotics and then you rebuild the microbiota, then that's a plan, right? That's a precise plan to replace something bad with something good. But if you just put a drug that, let's say antibiotic or lots of other drugs, they may be just trying to go after the symptoms and not the root cause. Now you just created a chronic patient that, like you say, is going to say, well, this is normal to me. Well, it's not normal, and I think you need to find what the problem is. Now it gets even more complicated, because some things that you eat could give you temporary discomfort, and that's again why you need the doctors and the clinic, etc. But this could be, let's say, for example, you eat chickpeas, right? So the chickpeas at the beginning could give you problems, and you think, oh, this is because I cannot eat them. But it may be not because you cannot eat them, but because you never ate them before. And so the microbiota needs to change based on the chickpeas. So the chickpeas are now going to drive the change in microbiota in this gut microbe population, right? In some people, that doesn't happen. So and this is why I tell people, start gradually, the legumes, and see how you react. At the beginning, it's okay to feel uncomfortable, to have a little bit of a problem. But then if 6 months later it didn't go away, you may not be able to eat that particular legume. But, for most people, 6 months later, you're fine. And now the bacteria that can process a lot of these prebiotics are generated, and you're fine. And that now becomes a good food for you.
So you have to microtitrate your chickpeas up until you can tolerate it.
Yeah.
I can probably say multiple things about this topic, but I'm going to move on because we want to sort of stick to the colon cancer screening. And I wanted to discuss some of the risk factors that impact screening. So these are the conditions that the doctors are on the lookout for and know that these people need to have, greater colonoscopies. So actually the hereditary familiar syndromes like Lynch syndrome, those actually just make up about 5% of the cases. Inflammatory bowel disease is also a known risk. So in ulcerative colitis, and we think in Crohn's, depending on how many years you've had the disease, how much of the colon is affected, and how inflamed a particular patient is, that all increases the risk. And you had the nice comment about putting cancer cells in an inflammatory situation. So in a ulcerative colitis patient with pancolitis, or most of the colon involved, in about 8 to 10 years of disease, that their risk of colon cancer goes up 5 to 15-fold. Now, our team and yourself has done a lot of preclinical and clinical studies with IBD. I wanted to have you comment, at least in the animal model, the differences, which are quite interesting between the water fasting and the FMD, and the extra benefits that came with the FMD.
Yeah, so that was not a cancer model, but it was an inflammatory bowel disease model. And it was interesting, and that's why, going back to the comments about prebiotic, it looked like the vegetables that were contained, they were rich in fiber, so prebiotics, the food for good bacteria, they were contained in the fasting mimicking diet, but were not, of course, in the water-only fasting, helped in this reshaping of the bacteria in the gut. So we went for, I think, the bifidobacteria, lactobacillus, some of the bacteria that are known to be very protective, went from 16%, 1/6, to I think 55% of the population in the gut. So by a combination of the vegetables and the fasting condition, so the fasting mimicking diet, it didn't happen in the water-only fasting. So suggesting that yes, if you shrink the bacterial population by fasting, and then you re-expand it, when you re-expand it to have the good guys, you have to have the good foods. So, and this went back to some of our strategy, this multi-pillar strategy, because we always, I mean, we could have done the fasting mimicking diet, all kinds of bad foods, right? It could still be, I mean, if I put lard in the fasting mimicking diet, it still have lots of the properties of fasting, right? Instead of putting, let's say, olive oil and certain nuts, et cetera, et cetera. So I think that was a good idea. Let's not just get fasting mimicking, but let's get fasting mimicking using foods that are associated with longevity extension. Yeah, so that's good. And it's also been good, I think, to train the brain of patients, right, as they do this, because lots of people might never have this type of foods. And after they do 2 or 3 cycles of the fasting mimicking diet, so now they're eating like that for 15, 20 days. And I think they recognize the value of those, plant-based foods. And they also recognize they can be vegan for a few days, a month, and they're not going to die.
I think this is a very important point, because I can't tell you how many times, most of the people that I've seen at the clinic, of course, are familiar with your work, but many people think that they can replace or get the same exact benefits with water fasting as with the fasting mimicking diet. And it's very interesting. I mean, you're getting the powerful effects from the fasting and then some, because of what you just talked about in terms of the specific ingredients of the FMD, which I think people probably don't realize.
Yeah, it's that, but also people don't realize the safety issues, the compliance issues. As you're starting to talk to lots of people, then you have to realize that you can now worry about, in general, this is okay. I mean, in general, people can do water-only fasting, but a percentage of people, or a majority of people in the long run, will have problems, right? So you may do water-only fasting 2 or 3 times, even 10 times, and nothing happens. Then you do it the 11th time, and you end up, passing out. Right. So, and we've seen it. We've seen it with lots of people that are improvising. Yeah, so I think stick with the things that are clinically tested in many clinical trials. Stick with the things that are tested out there on hundreds of thousands of people, and I think that's much safer. And at some point for disease treatments, it's going to be FDA approved. That's a hope that some of these will turn into FDA approved interventions.
I'm going to move a little bit and talk about another risk factor that should alert physicians to be on the lookout for colorectal cancer, and that's abdominal or pelvic radiation. It has been noted that especially with prostate cancer patients or other types of cancers where people are getting radiation to the abdomen or the pelvis or the spine, this can increase risk based on two big studies. So I wanted to ask your advice on using fasting or FMD during radiation. Can that help protect the normal cells?
Okay, I'm gonna now answer as a scientist, so I think that this is really gonna be the decision of the physician and the patient. So I can tell you that we expect that to be the case, meaning that we expect, based on everything we've seen, that normal cells will be protected, and cancer cells will be damaged by the fasting mimicking diet, but it's by no means ready for general recommendation. It's never been fully tested clinically. So we don't know, and so I think that the question is the person doing the radiation and the patient will have to sort of think about what the risks are, right? So if somebody is really troubled and is going to get the radiation for a very long time, and the doctor thinks you're gonna risk getting colorectal cancer or whatever else because of this radiation, and there's a high risk, then I would say that's probably something I would discuss the fasting mimicking diet. But if somebody is very low risk, there's a one in 1,000 chances that they're going to develop colorectal cancer because of it, then I would say probably stick with maybe the longevity diet, going in there, with the right changes, but not necessarily extreme changes, right? So the longevity diet will give you some of the same benefits if you do it all the time. Let's say I will start the longevity diet at least a month before the radiation, and carry out through the radiation. So this is a pescatarian, low protein, et cetera type of diet. Yeah, say if you do that for a month and you continue it through the process of radiation, that would be much safer, I would say, way to do it. And you have to eat something. So I think that that's fair to say that probably, since no diets have been tested, right, for should you eat meat, or none of this is known as far as I know, for what you just said, for the secondary problems of radiation. So I would say, yeah, longevity diet, and keep it throughout. Make sure you do, as we've shown for the clinical trial in Italy with breast cancer women receiving hormone therapy, they were doing muscle training. Make sure that when they were on these longevity type diets and fasting, they were not losing lean body mass, and in fact we showed that they were not. So I think that, yeah, if you do some muscle training, you're probably going to lose some fat, but you're going to keep on the longevity diet the normal muscle mass.
Yes, I'm trying to focus on colon cancer, but yes, you are right. We're talking about colon cancer and many other chronic diseases. And on that note, I wanted to sort of, with specific emphasis on colorectal cancer, obesity and diabetes are huge risk factors. And again, there's some common pathways. So weight gain in early adulthood and midlife, which is sort of at a peak now, creates a modest increase in risk, and obesity. People seem to have a higher likelihood of dying from colorectal cancer if they are obese. I was really fascinated by the diabetes studies because I thought, I read that there's a 8% higher chance for a diabetic to be at risk for colorectal cancer. And I thought, okay, maybe that's a more advanced diabetes patient, maybe on insulin. But in fact, there was a JAMA study in 2005 in Korea where they looked at the elevation in risk came from fasting blood sugars greater than 125. And I was shocked that these were type 2 diabetics. These were not even people on insulin. So I wanted to get your explanation on the commonalities of obesity and diabetes and why the increased risk in cancer.
Yeah, so what you just said, for example, right? So now you have a very high level of glucose. And most of we've done lots of studies on colorectal cancer, and lots of the cancer lines love sugar. So now imagine having all this excess sugar, and that's the difference between maybe having one cancer cell that survives and can make it to the next level. And that's all you really need, right? So that one cancer cell that escaped the immune system and they can survive. And this condition, not just, so the diabetic is going to have high glucose, high insulin, high IGF-1, et cetera, et cetera. And so all of these things together are gonna help the cancer survive, the initial cancer cells survive, and then grow and then invade, right? So all those steps are aided by those conditions. So that's why it's so important to make it hard at all levels, right? So not just the sugar. I mean, because they saw the sugar high, let's say 125, you say, but that's, of course, we know that that's also associated with high insulin, right? And in the great majority of the cases, you're going to have high IGF-1, right? So now you have all three. Yet they saw only one, but you have all three in a diabetic patient. And we know, for example, a recent paper in mice, but also humans, looking at hormone therapy. So when we added the fasting to the hormone therapy, it worked because it reduced IGF-1, insulin, and leptin, right? So it didn't, in this case, glucose was not important, but IGF-1, insulin, and leptin were the three factors that were very important. So having any one of the three can aid the cancer in its early stages, and in fact, even worse, it can aid the cancer before it is a cancer, right? So, for example, years ago, we took the blood from these people down in South America that are low in insulin and low in IGF-1, right? And regular glucose level. And then we took human epithelial cells, the type of cells that give rise to colorectal cancer. And then we exposed them to carcinogens, either in the blood that had low IGF-1 and insulin, or the regular blood. And the interesting thing was double. The low IGF-1. So let's say a diabetic compared to somebody that has got the longevity diet, right, and is perfect weight. So now, if you take the blood that has got a high insulin and IGF-1, what happened is the mutation, the DNA was much more mutated. So even before you get the cancer, now you're setting yourself up for cancer, right? Because you have a much higher damage of the DNA, and so the chance that you're going to get a mutation in p53 or some tumor suppressor or oncogene is much higher. And then once the cancer was established, once the damage was established, if they were in the low IGF-1, low insulin, they were much more likely to die. Right? So a dual protection against the cancer, because you get less damage to the DNA, and then if you do get the damage to the DNA, if you're on the right diet, the cancer dies, right? The cancer cell dies, right? So it's two layers, very important, right? So that's what people want to have. You want to have these multiple layers of even before you get the cancer, but then if you do get the cancer for whatever reason, then that could still even much later allow the right diet to potentially get out of it. But yeah, so those are some of the reasons why a diabetic may be such a high risk for colorectal cancer. And 38% is very big. You know, it's not,
Yeah, very.
this is not a small. This is telling you how central. This is proving essentially how central diet is too, because diabetes is almost completely. I mean, for the great majority of people, is completely nutrition dependent. So that will tell you that. So for the majority of people, if you completely change the nutrition of a diabetic, at least in the early stages, you can bring them back to a non-diabetic stage. And so, yeah, that pretty much tells you that nutrition is very central in the colorectal cancer, even more than the epidemiological data would suggest.
You talk about IGF-1, and for those listeners who are not familiar, we just discussed a case of a patient at the clinic and discussed low IGF being a problem. It's something I do measure in patients. Can you tell us why low or high could be a problem, and why we care about that level?
Yeah, so low is not a problem as a cause, right? So we have these people that we've been following for 20 years. They have almost zero IGF-1. Not only they don't get cancer, they don't get anything. You know, they're protected from diabetes, cancer, cognitive decline, right? So we know in both mice and humans, low IGF-1 is not a problem. The problem is when the low IGF-1 is the consequence of another problem, right? And which is very common. So for some reason, IGF-1 responds to big chronic problems. So if you have massive inflammation, IGF-1 goes down. Cancer patients, I think that's one of the situations where you see IGF-1 going down. So it may be that the body is trying to compensate for a big problem by reducing something that can make the problem worse, right? And it will make perfect sense. I mean, we don't know for sure, but that's one of the hypotheses. Yeah, so when you see IGF-1 50, then you have to wonder what's going on. You know, is there frailty? Is it very poor nutrition? Is it in systemic inflammation? Is there some other disease, maybe hormonal problems? Yeah, so those are some of the things that can explain why low IGF-1 is clearly associated with high mortality.
And high IGF, what processes is that?
So, and high IGF instead is usually, or it can be in most people, lots of proteins and lots of sugars and lots of, believe it or not, milk products, right? That's what we're about to publish a meta-analysis on this. And it looks like milk-based products for some reason, and we're not clear, and we're not the first one talking about this. I think there was a New England Journal of Medicine paper that talked about that. So for some reason, milk-based products seem to be associated with higher IGF-1. So lots of calories, lots of sugars, lots of milk-based products, and lots of proteins.
On the milk-based product, do we know cow's milk, goat milk? Does it matter?
We did not have the data to distinguish between the source. It was just milk, some cheese consumption, etc. So it seemed to be, and even calcium, I think, was one of the ones that, because probably people that have high calcium have lots of milk and cheese. So those are the calcium, and it was striking because there were not too many things that are associated with it, but lots of the milk associated. The milk-based foods were associated with high IGF-1 levels.
That's very interesting. I want to move to the topic of red meat, which is, of course, very upsetting for some people. But in 2018, the World Cancer Research Fund actually concluded that the consumption of processed meat, which is, and I did not know this, is classified as group 1 carcinogen. This is your hot dogs, your sausages, your ham, beef jerky, that kind of stuff. So it carries the same risk, category 1, as asbestos, cigarettes, and alcohol. And it's definitely been a risk factor to increase colorectal cancer cases. Now, the consumption of the unprocessed red meat, that is still thought of as probable. What I found interesting is, and a lot of people on keto diets and having a lot of bacon. I mean, that sort of became kind of fashionable a few years ago. All the bacon you can eat. I didn't realize that as little as 50 grams of processed meats can be a problem consumed on a daily basis. That's only a few slices of bacon. So I wanted to get your thoughts on why, what factors. I mean, they think that maybe it's the way that we're cooking or the heme. Well, what is it that causes a problem? And do you think there's any amount or type of meat that would be okay, red meat, that would be acceptable?
It's not known. I've looked at the data a number of times, and it seems to be distinguished from at least for colorectal cancer, from the protein intake. So it's interesting. I'm not sure that I'm convinced, but that's possible. It's possible that unlike what we've shown for the overall population, for which high protein intake is a problem, that in the case of colorectal, it may not be as much about protein intake, but about the specific type of food, like processed red meat. So is it maybe that comes? That's some of the things that I will look into. Does it come from animals that have been treated with more growth hormones, steroid hormones, that type of thing? Does it come from animals that have been given more antibiotics, et cetera, et cetera? So I think that those are some of the things. I mean, Europe, for example, is much more regulated than the United States in terms of what the animal can be fed. And in the United States, some of the things you hear are pretty scary. And, and I don't know enough to be a judge, but I know that in general, that's the case. There is a lot less regulation in the United States on meat because, of course, the meat lobbies are very powerful. We've experienced that when we say that high protein is as bad as smoke. And we took it from the actual NHACE database that the risk, by having high protein, the risk of cancer went up the same way that it was, I think it was between former smokers and current smokers. It was in between, right, that the risk. And we got attacked because lots of people are benefiting from selling high protein foods, including red meat, processed meat, particularly, et cetera, et cetera. Yeah, so I think it should be pretty much eliminated from the diet, until you get to, say, age 65, 70, and then I would just focus on the sort of like organic or whatever you can afford, but certainly not processed meat. But I think the world is also going to move more and more towards a vegan state. So I would say that, because of that, I also think there is an equivalence that are much more healthier. The fish, certainly, and the plant-based food. So I think that even for the 65 and older, it's probably better to minimize really eliminate virtually the processed meat, and then minimize the let's say organic or grass-fed meat consumption.
And just one last comment on that. One of the issues that seems to be a problem is the way that the form of cooking as well. So high heat, barbecue type of meat seem to release carcinogens, and so the way that you cook matters as well.
Yeah, so we talked about it that in the third book, which is not in the US. Second and third book, we talk about that. Yeah, so there are specific procedures. Hopefully, we get those books translated soon, and people can get them maybe to the foundation directly and read about that, because we had all kinds of tricks that people can use to avoid the modification of the foods, not just meat, all kinds of foods that are modified by the cooking method, and so we added that.
We look forward to those English translations. In the interest of time, I'm going to probably I was going to talk about protective factors. We've talked about some of that in terms of the ideal diet. There was actually a JAMA study looking at these are protective factors specifically for colorectal cancer. They did look at a vegan diet, vegetarian, semi-vegetarian, and pescatarian. And in fact, the vegetarian, pescatarian did the best in terms of reducing risks, so which is completely in alignment with the longevity diet. And I think, and the added benefit of fish and omega-3s.
And please point out that usually, not always, but usually the vegan diet is not part of that. And remember the immune system, right? So the vegan diet, there's a recent study that came out on fractures. So the vegans were 2.5 times more likely to get fractures. And the vegans, I think about 20% of them are nitrogen deficient, meaning they're not getting enough proteins. So you can be vegan and you can be very healthy, but to be vegan and be very healthy, it's our job, right? So you need to pay attention, lots of attention. And even then, 2.5-fold is an extraordinary result, suggesting that just like the bones are weakened by the vegan diet, lots of other things could be weakened, including the immune system. So I think that then, and why is that? Well, the vegan diet has an amino acid profile. If you only eat legumes, there's several amino acids that are going to be very low, right? So, and this is why in some of the things that I teach for the registered dietitian program at USC, I tell them add different sources of vegan protein, like the seeds and the nuts, right? Because if you have legumes, seeds, and nuts, now you can at least ameliorate the problem. But most people may have just a couple of sources of protein, plant-based, and they're going to get in trouble in the long run.
It breaks my heart, even though I quote that study to some patients. They're absolutely, not willing to make modifications, and even when they know they have thinning bones, and they're getting treatment for that. So
yeah, and again, if that's a religious reason to be vegan, fine. But then at least pay attention to the changes that you need to make within the vegan diet. More proteins, more variety. And then I think in most cases they're going to be fine. Once, especially the proteins and the amino acid profile is back to normal, I think that they'll be fine, even if they only stay vegan.
I'm going to go really fast in terms of other things that are very important. Getting adequate fiber, about 20 to 35 grams per day. Getting resistant starches. And adding fish, all of which is definitely, all of those considerations are part of the longevity diet.
And by the way, please buy the book. It's a foundation book. I don't make a penny out of it. 100% goes to Cure Foundation. And it allows Shadi and the team at and Shadi is the medical director of the Create Cures Foundation Clinic. And it allows them to really spend more time with the patients. And so the book is one of the ways that we found this ability to help people also that cannot afford it to have this sort of team at their service, and that team includes me. So at least in the complicated cases. So please buy the book, and I always say buy 10 copies and give it to all kinds of people. It's 30 years of my work, but not just my work, the work of hundreds of laboratories, hundreds of clinical trials, and it's all in there, and it benefits the foundation, but also the patients that are going to come to the foundation, which probably includes some of the people that are listening now.
And it actually is, there's recipes and very nice charts. I'm going to talk in a little bit about the nutrients that are important for colon cancer. There's great charts of, how to increase folate and B12 in the diet, and I still use it as a resource. Moving on real quick, because I want to highlight the things that you've seen in your research. I want to focus on nutrients that may be beneficial to the colorectal cancer patients specifically. Can you talk about vitamin C? Of course, is a hot topic. Regardless of the type of cancer people have, I see people doing all sorts of infusions, oral supplementation. Can you tell us what may be unique to colon cancer and why it may or may not be beneficial?
Yeah, so last year we published a study where we combined the fasting mimicking diet with the with injectable vitamin C. This was a mouse study. We also had a couple of patients we followed, and that looks very promising, but we did not include them in the paper. And I mean, obviously, improvisation is a very bad idea in this case. It was not pills. It's not vitamin C that you take orally. It's high levels of vitamin C that is injected. And so this should be done only in, first of all, should only be done with KRAS mutated cancers. It did not do anything to the other colorectal cancer cells, but the KRAS mutated. So if there is a KRAS mutated cancer, then talk to your oncologist about. And now we're in collaboration with Heinz Joseph Lenz. We just applied for some funds to do the pilot study on that high injectable vitamin C and fasting mimicking diet and in the treatment of KRAS mutated colorectal cancer. So we'll see if we get the funds. But certainly, I know that they have had patients that combine the fasting mimicking diets with all kinds of other standard of care therapies at the USC clinic. And so I think it's a discussion to have, particularly to have with the oncologist, particularly, and with you at the foundation, particularly for those that are in trouble, right? So whatever you're doing is not working. So that's when I think it's very, very important. You come to the clinic and you go find some oncologist that is willing to try things that are safe, that scientifically make sense, but that could actually work, even though, because you see, for example, in this case, I'm talking about a pilot study with 10 patients in it, right? So that's going to take us another year and minimum to do this. You got to get funding. So then we have to organize a bigger study, and that's going to be 150 people. Then, so this is so slow. The process, the clinical process is so slow. It might take 7 or 8 years to get to the end of this. And because there is not a new drug that can make, pharmaceutical company billions of dollars, it goes very slow. We have to rely on the government to give us some money, the foundations. So it's almost an impossible track to get this alternative or integrative interventions approved by the FDA. So, I mean, we're trying to do that, but I'm saying that's why I say I know a lot of oncologists don't like to hear that. They're like, oh no, there's no FDA approval. But if the patient is not responding, I think please, work with Shadi and others and say, look, it's not realistic to expect that, especially because, and it's another problem that people don't realize. By the time let's say you combine vitamin C with the fasting mimicking diet for colorectal cancer, and let's say that it works very well. Now, 2 years on the road, by the time we're done with that, there could be a new kinase inhibitor that is using colorectal cancer as standard of care. And then we're back to zero. Now we have to do 3 drugs, right? And we're not allowed to go without the drug number 1. So that's a flaw of the system. It's so slow and it's so piece by piece that it's great if you can wait, but it's terrible if you are in trouble. And it's just really, in some ways, irresponsible, I think, in the way it is for those that cannot wait. They got to come up with a better system to say, sure, if you can wait, if you have a stage 1 problem, colorectal cancer or whatever, it can be removed, FDA approval, surgery, procedure, and all of that. If you cannot wait, and if your oncologist just told you, you're in trouble here because we tried all we could, it's not working, or we're going to put you in a clinical trial that it's got a 1 in 100 chance of working or whatever. Well, I think that's when the integration part, things like the fasting mimicking diet, where that you're affecting glucose, you're affecting insulin, IGF-1. And we already know, I think most oncologists will agree that that's probably good to have lower glucose, lower IGF-1, lower insulin, right? So why not? Why not say, okay, let's get you that. And just in case that it works for you, we know the diabetic, because of having glucose over 125, are in trouble, right? For colorectal cancer. So why not give you let's bring down your glucose, right? Let's just use it for that purpose, if nothing else, and then we give you the standard of care. But there's a lot of resistance to this type of thinking, and it's just really bizarre to me that is not standardized for the benefit of the oncologist, the integrated doctor, and the patient. Right? We need to have a system that allows this to happen rapidly in a very careful manner.
Well, and on the other extreme, that I have not even shared with you that the types of therapies that people are doing in these advanced cancer cases, that, it breaks my heart that they are traveling great distances for various kinds of infusions, spending a lot of money. And a part of what I do is get serious about, you want to be focusing your attention on things that we know are going to make a big difference, not spending a lot of time and
money, right? And money, and with all kinds of quackeries. So yeah, that's exactly the even bigger problem. Now, people are still going to do it. 60-70% of cancer patients are going to go to Google, and they're just going to say, my oncologist is not helping me. And so I'm going to go do my own work. And then you go from bad to worse, right? So absolutely. So somebody, and maybe the FDA needs to come up with something that will allow a team of professionals, including the oncologist. And the oncologist can always say no. I mean, I agree with that. I think it's important that the oncologist could say, you show me everything, you want to do this, I'll say no, or find another oncologist that is willing to allow this. But it just doesn't seem like that system is even existing. Whenever I present to oncologists, they, most of them look at you like they want to do the clinical trial. So they're very receptive to that. But they're completely against any of this moving into the therapy unless it's FDA approved. And because of the things that I just said, it's like, how are you going to get, lots of these things to be FDA approved? Isn't it better that we combine like a multidisciplinary, let's say integrated medicine? You, Shadi, as a physician, you can say, look, as an integrated doctor, I make my decision that I want to reduce IGF-1, glucose, et cetera, in this cancer patient. And then the oncologist can disagree with you, but being a physician, you can be much more forceful. And if you had the authority, I think somebody gave you that authority, I think you could be much more forceful in talking to the oncologist. Say, are you sure? Because this patient is not responding, and so isn't this a good idea, right? And if not, why not? So that's what's missing. And I mean, I don't know. You can tell us about your experience, Shadi. In approaching the oncologist, it seems to me like you still have to struggle to add anything. Is that true?
For a good part, yeah. I mean, what I see is that patients are doing things sometimes without telling their oncologist. I can't tell you how many times they're on many supplements and they're not informing their oncologist. Imagine they're on vitamin C and various other things while getting chemo, and they just know that the oncologist doesn't want to hear it, and I have to say, no, you cannot take these things.
Well, especially you give a great example, right? Especially because vitamin C is now an antioxidant. And vitamin C, especially with the KRAS non-mutated colorectal cancer, can now interfere with the chemo, right? So now you may be able to protect the cancer cells, and there are several studies suggesting that because you gave high-dose vitamin C before the chemo. Now, we've done that. We added all three, and it worked better than two. So in the KRAS positive, fasting-making diet, vitamin C and chemo worked very well. But you don't know, and it's in different cancers it could go in the opposite direction.
Yeah, and even the most, vitamin C, of course, we all think about, but so many other supplements that we think of as benign. You do not want to be taking these things during chemo, and they are either not telling the oncologist, they're doing things on their own. I can't tell you how many times I've heard of people doing week-long water fasts without telling the oncologist. It's just frightening. And I think, yes, when I talk to oncologists, it's either I don't get a call back or I send a lot of papers and don't get a call back. But I think things are very, very slowly changing. As you know, we have mutual colleagues that are interested and are open-minded, and that field of integrative oncology is growing. It just needs to be a lot more doctor-to-doctor education, I think. We have gone a little bit over. I just wanted to touch on a few other nutrients that may be of benefit. Folic acid, B6, and vitamin D are super important and may offer some benefit in terms of risk. Since we went a little bit over, I wanted to ask you, is there anything else that you wanted to mention before we close this particular topic?
No, I think we covered it. So
we covered it all?
We did.
Okay, great. So in closing, I wanted to thank you, Professor Longo, not only for your time today, but for being a great resource for us in managing these difficult patients at the clinic. We hope you've all enjoyed our conversation today on the topic of colorectal cancer, and that you will consider consulting with our team when you need clarity on what to eat, when to fast for optimal health and longevity. Thank you.